Hey, good evening, everyone. This is Dr. Dennis Patterson in Reno, Nevada. I'm with Nevada Advanced Pain Specialists and looking forward to tonight's webinar. We figured what we've been looking to provide with a lot of our members is some information on minimally invasive spine. And tonight we've got a wonderful presentation. The agenda is pretty well laid out. What we're trying to do is we figured your offense should be your best defense. You know, what can you do to prevent the complications before they actually happen? And so we wanted physicians that are well experienced in these procedures to talk about what they do to prevent complications from occurring before they do. And so first we're going to start the evening out with Dr. Aaron Kolodny. He's with Precision Spine Care in Texas. And then we're going to go to the world famous Rick Pacious in Orange County. He's at SC Spine and Pain. And then after that, Dr. Michael Dorsey, Vice President of our society, is going to come on, and we're going to have a good panel discussion with Dr. Kolodny, Dr. Pacious, myself, Mike, and his colleague, Dr. Andrew Vivas from UCLA. So it should be a pretty good conversation. I mean, honestly, we could probably spend all night just going over the cases and talking about that. And then at the end, we want to go over the questions that you as the attendees have from watching tonight. So please, in the chat box, as the night goes, we may not get to your questions immediately, but we will filter through as the presentations go. And at the last part of tonight's webinar, we plan on answering your questions for you, putting them out there for everybody to hear and answering them for you. So I want to thank you for joining us tonight. And with that, let's go to the next slide. I'm going to invite Aaron Kolodny, my dear friend, to come on and talk about how, you know, our offense is going to be our best defense. So thank you, Aaron, for joining us.
Welcome, everybody. My name is Aaron Kolodny, and I am the Director of Clinical Research at Precision Spine Care in Tyler, Texas. I'm going to spend about 5 to 10 minutes talking about things that you might consider preoperatively to prevent problems intraoperatively and postoperatively. So I'll identify a few key steps you might consider in the preoperative period, and then I'm going to give you a little bit of a kind of a pre-op checklist to sum it all up. So it all starts with a thorough history and physical examination, and that's going to help you prevent the most common complication, I think, of minimally invasive surgery, because minimally invasive surgery inherently, in regards to typical surgical complications, has a low rate of complications. That's why we like it. But one of the complications, of course, is non-efficacy of the procedure, either due to poor surgical planning or poor patient selection. So it starts with a history and physical to make sure you select the right patient for the right procedure, but also with that history and physical, you can identify comorbid medical conditions that can increase the risk of complications, and a brief surgical history from the patient can uncover any previous problems they've had with wound healing or intra-op or post-op bleeding or anesthetic related issues or post-operative wound infections. And if you know about these, that these have occurred in the past, you can use steps to mitigate them occurring during the surgery that you are going to do. So of course, smoking cessation is important because smoking impairs blood flow, oxygen delivery, it hinders angiogenesis, and it can cause delayed healing of wounds, increase the risk of infection and of non-union of a fusion if you're trying to do a fusion such as we do when we try to fuse the SI joint. Similarly, our patients with diabetes, and I don't know about y'all, but I have a lot of diabetic patients that come in to see me with pain-related issues. Poor perioperative glycemic control is clearly associated with delayed wound healing and increased infection risk. And also, your poorly controlled diabetics may also have poorly treated associated cardiovascular pathology, which would be nice to know about. Looking at hemoglobin A1C, that's about a 3-month look back. It's a reasonable thing to do. And a value of 8% or less is really a reasonable goal. If you start getting above 8.5, the complication rate starts to go up. But more important than hemoglobin A1C is glycemic control, is blood glucose control in the perioperative period. And we strive for no higher than, say, 180 to 200 milligrams per deciliter at the time of the incision. One thing that we don't look at very often, but if you know about, should be considered, and that is bone density. Your patients with osteoporosis with T-scores less than -2.5 may be associated with lower fusion rates and increased risk of instrumentation failure or subsidence. And if you are aware of this in your patients, you might consider supplementation with calcium and vitamin D, weight-bearing exercise, and bisphosphonates prior to surgery. It also could have a role in your choice of surgical technique now that we have multiple options for many of these procedures, particularly multiple options for SI fusion. You might change your choice of implant if you know about a significant degree of osteopenia or osteoporosis, or consider the use of a bone growth stimulating agent such as a BMP2 like Infuse or iFactor, which are expensive but effective. In regards to infection, it's important to safeguard your patient by identifying and treating any systemic or local infection prior to surgery, of course. Optimizing glucose control, I mentioned that. Smoking cessation, we already talked about that. We screen all of our patients for staph colonization and decolonize carriers with intranasal mupirocin and chlorhexidine showers for about 5 days preoperatively. Certainly provide prophylactic antibiotic preoperatively at an appropriate weight-based dose, generally within 60 minutes of incision, and options that are validated would include, of course, cefazolin, clindamycin, and vancomycin. Antiplatelet, anticoagulation therapy management is important, and I would suggest that you do as I do and refer to published guidelines. I use the ASRA guidelines. But recall that this is a shared decision between the patient, the interventionalist or surgeon, the prescribing physician, because there's a balance between normal coagulation and the risk of a perioperative stroke, heart attack, DVT, or PE. So now that we're talking about doing SI fusion in the office setting, the importance of normal coagulation becomes even greater because some office settings may not have a proper bovie, may not have proper suction. And so you don't want to be in a situation where you get into bleeding that is a nuisance in a setting that you don't have the proper tools to handle. Imaging studies are important to prevent complications intra and post-operatively. You need to obtain appropriate imaging to assess the anatomy and plan your surgical approach. A CT scan can be very helpful for planning a minimally invasive SI fusion procedure. As you know, the SI joint is quite complex and quite varied in its anatomy. And using a CT preoperatively, you can determine a good course, a good trajectory for your instrumentation and implant placement. Also, it's helpful to use CT or MRI to ensure that there's enough bone present for an interspinous device to be used in patients that have had a previous discectomy, where some lamina may have been removed or some dorsal spinous process may have been taken down as well. You can also use your imaging to correlate and review available imaging to ensure that you target the proper level in the case of a nomenclature issue. Many of our patients may have a lumbarized or sacralized segment. You need to make sure that you correlate the preoperative imaging with your fluoroscopic imaging to make sure that you are targeting the proper and intended level. And lastly, to keep you safe, educate your patient about the procedure, the potential risks of the procedure, the benefits, and realistic expectations, and get all that together in an informed consent. So, in summary, a thorough history and physical examination can help you choose the right procedure for the right patient. It can help you identify any comorbid medical conditions that need to be treated. Talk to your patients about smoking. Diabetes control is important. Optimize their physical and nutritional status, screen for infection, and if colonized, treat. Have a plan for antiplatelet and anticoagulation therapy. Use the appropriate pre-op antibiotics and coordinate all this with your surgical team. A few minutes or a few things that you can do preoperatively can really help the perioperative and postoperative periods to go smooth without complication. Thank you.
Thanks, Aaron. Appreciate that. I just want to remind everybody, I'm looking through the chat room. I don't see much yet. If anybody has any specific questions on Aaron's topic tonight, feel free to reach out. Just one thing I want to point out is that the Noridian here where I'm located, the SI LCD now requires not only a CT or MRI of the lumbar spine, but it's also requiring it to be of the SI joint. So I just want to throw that out there. Um, you know, there's 5 different MACs. You just got to make sure that you're following the one for yours. They may be different in different parts of the country. The nice part about PSPS is, you know, we're pretty much all West Coast, and so just make sure you're familiar with yours. You know, I've read the Noridian one backwards and forwards. With that, I'm going to invite Rick on. Rick, if you can come on, we want you to kind of cover the intraoperative considerations, you know, so the day of surgery when you're treating a patient. What are things you think about to prevent any complications while doing these types of procedures?
Thanks, Dennis. First of all, great job, Aaron. You know, you always do an amazing job. Let me get this in here. Where am I going here? You do a great job, comprehensive. Tagging on what Aaron said, one thing that I always do in a preoperative situation is we actually mandate that people do a HIPAA cleanse shower 3 nights before their surgery. And what that entails is take a shower in the evening, take the HIPAA cleanse, and basically from the neck down to the feet, except for their private parts, that you put the HIPAA cleanse on, let it kind of get sticky for a minute, wash it off with the shower, and then clean sheets. And that we do that 3 nights in a row. That also has been shown to prevent infection. Obviously, he's got a bigger audience in Texas than we do in Newport Beach. And our cutoff for hemoglobin A1C is 7. Smoking, good luck. I mean, the one thing that we do is we, encourage them not to smoke the night before, the day of, which can make a difference from an anesthetic standpoint. But once they're in the pre-op, I typically use vancomycin and gentamicin unless there's contraindication or allergy for these cases. Once they're in the room, once they get the antibiotics, a good half hour before you start your procedure, you close the door, and if you have a lock, you lock the door. Good friend of mine, Robert Levy, I'm sure most of you guys are familiar with him. He always talks about in his OR, once they get into the room, he puts this big, police tape over the door, do not enter at risk of death. So I think closing the door and locking the door, if you can, from the inside is essential, because literature coming from the total joint replacement literature shows that the more the door opens during surgery, the greater the infection. So if you have the door opening 4 or 5 times, every time that door opens, your chance of infection increases. The prep. So I can't tell you initially when we first started doing all this, I would have my goes this way, my nurse scrub would prep the patient, and I'm like, the battery, we're just doing a battery swap, and it's over here on the left lateral flank, and you've prepped everything over the whole back, and I'm like really compromised as to where the surgical site is. So either get a good relationship with your staff and instruct them where to prep, or be in there during the prep, which is not a big deal, and make sure that the prep area is appropriate, that you've got plenty of room to operate. If you need to position the patient a little differently with a wedge or whatever, that's great. That's another thing. While I'm thinking about it, if you're familiar with the NAC guidelines, NACC, Neuromodulation Appropriateness Consensus Committee, it's invaluable, both from preventing infection, preventing complication neurologically. There's, I think, 5 different sets of NAC guidelines. The newest was cervical stimulation, and I think that's critical. And what they do is they talk about all this stuff, and at the end they have like 15, 20 points that, this is important, this is important, this is important. It's very simple, very straightforward, easy to obtain on the web. If you have like Elsevier access or some of these other accesses for journals, but also significantly incredible. So I do a lot of neuromodulation. And when we look at neuromodulation, when Nevro came out, I don't know what, probably what were we, 2004, so probably 7, 8 years ago, maybe longer, but I think it's 8 years ago. They came out with put these leads at 9 and 10, and it was easy. So sadly, most neuromodulation is done by people who do 10 or fewer a year. So you got to think about that. If you're say you're going to get a total hip replacement, and you went to a guy who did 1 a month, I mean, would you? Probably not. So with neuromodulation, when H10 came out, they said just put it 9, 10, you don't have to think about anything. The whole field of neuromodulation turned into plant and pray. So then each company came out with their own deal. All right, Boston's going to be at 7, 8, Abbott, 8, Boston, wherever. I mean, it's like, you don't have to think about it, just put it there. And 75, 80% of the time, that works. But when we neuromodulate, we look at targets, and we know that maybe 7, maybe 10, thoracic is going to be the target. Maybe conus. Conus is great. People don't know about that, or it's not very well published about stimulating on the conus, so right below the conus, which is really helpful for lower extremities, or peripheral, or DRG, or a peripheral nerve stimulation. So you should know where your targets are. If you have like a complicated patient that you think, well, you've got back, but you've got just L4 pain, and you want to make sure you pick that up where they've got more S1 pain, which is another story. So if you put your leads in the normal position, or the standard position, you may or may not get much, capture on that level. So understanding neuromodulation and looking at these different targets that you can do. And if you're sure that it's a kind of a complicated, weird thing, do an awake stimulation. I mean, it's old school, and I do it once in a while, especially for pelvic pain when I do conus stimulation. But I think that's a whole nother story. So another big topic that's come over the last few years is neuromodulation. In California, if you're in your own ASC, which I am, and most people on the West Coast either own their own ASC or they're part of an ASC that they have ownership in, the finances don't work. You can't 6:49 p.m. You can't do neuromonitoring financially. It doesn't work. So with that in mind, if you're doing stim, if you're doing, a Minuteman procedure or an SI fusion thing, none of this applies, but the tenets that I outlined earlier absolutely do. But if you're doing stim and you're not sure that you're going to cover what you need to cover, give them a little juice up front, put the needles in, and then let them be aroused enough where they can respond, but they're not, that with it. But if you put the electrode in the wrong place, they're going to respond. So you've got that light monitored anesthesia. And then don't be afraid to test if you want to do that. I mean, intraoperative testing is a long gone technique that still has a lot of value. And again, neuromonitoring can be very helpful. There's, like I say, the last 3 years have been phenomenal as far as all the publications. In my own, I'm not going to argue with that. So then intraoperatively, okay, so you've locked the door, nobody comes in or out. You've got your prep. They have the appropriate antibiotics ahead of time in a timely fashion to be effective. And then subsequently, when you get into your case and you're finishing up, you irrigate. Copious amounts of irrigation. When I do a stim, I do a liter of irrigation for the pocket, and I do a half a liter for the stim side for midline incision. Some people continue to pack the generator site with vancomycin. There's no evidence that does anything. And what happens is if you do place vancomycin in the pocket, you get this you can get this, you get a red man syndrome when you give vancomycin intravenously and they get all flushed and red. Well, commonly, if you put vancomycin in the pocket, you're gonna get this big redness over there, and you think, oh my God, I've got a cellulitis, so I got to treat this. It's not cellulitis. It's just the vancomycin hyperemia that occurs from there. Um, and I think that those are the most important things. Is number one is keeping that door closed, having the appropriate prep, having the appropriate irrigation, and having an appropriate plan for what your attack is for whatever you're doing. My focus is STIM. I do SI joint. I do a fair amount of Minuteman, so forth. And that's, you're going to go here, and that's where you're going to go. So I think those are the key essential things that you want to do intraoperatively. Dennis, back to you.
Hey, thanks, Rick. Appreciate it. I think if Aaron's available right now, I'm going to have him jump on too, and also bring on Mike. We do got a few questions in the chat box that we figure that are just perfect for your guys' current discussion. The first one is about BMI limit. Do either one of you guys have a BMI limit for treating anybody with minimally invasive spine?
I don't have a specific limit, but at the hospital where I do my work is a it's a low acuity hospital. We don't have an ICU. It's an orthopedic hospital, so BMI of over 40 is not. We can't do those patients there. So I guess it's I typically won't be seeing those patients. Now for other things, for like I go to the big hospitals, I'll do things like pumps and stims on those patients. But for the typical minimally invasive things that we're talking about here, I don't have a specific BMI limit, but I don't, 40 is about as high as I'll go. That's reasonably big. That's Texas sized anyway.
Yeah, that's kind of our cutoff in our community as well, is 40. Anytime you try to put have a case at the surgery center and they catch that, they'll instantly text or call me and say, hey, you either got to go to the hospital or you should really reconsider doing this. Rick, is it different down in your community down there in SoCal, or is it 40 about the limit as well?
Yeah, I mean, I think what happens is, you're going to look at an individual. And BMI, again, if you look at what BMI was, that's a societal measure. So when BMI was first introduced, it was an epidemiological thing. So I'm pretty fit, and I'm about 200 pounds, and I'm 6'1". And when I had my hip replaced, they said I was obese. And I'm like, okay. And they wanted me to go through this obesity protocol. And I'm like, no, I don't think so. So again, BMI was developed as an epidemiological thing to study populations, and as a general overall analysis, it's a good thing when you're looking at epidemiological stuff. When you see someone in your practice, like I've got this guy who's just a big dude, and he's I don't know, he does something physical for a job. I don't know, he's an iron worker, I don't know, he lifts cars up in the air, or whatever he does. And even though this dude is technically a BMI of 40, he's a robust individual and very muscular, but also fat. He's also fat. So you can't look at a number as a number and think that that's the answer. You have to look at the individual. Now, granted, in Newport Beach, it's probably not the same population that Aaron sees. I would say probably half the size overall, but you've got to take that into consideration. And when someone is normally obese, and if they're like just a really, they're not muscular, they're mostly adipose, you just got to ask yourself, is this worth it? And so the number, I think, is a barometer, but it's really not like a cutoff. It's a variable that you consider.
Yeah, I agree. All BMIs aren't the same. You can have a weightlifter that falsely is elevated and they're actually pretty fit. So I agree. You got to take the individual into account. Now, Mike, you got a question for them, or?
Yeah, I did. For Dr. Kolodny, is there a depth at which the instruments for, say, mild, or even for a posterior SI fusion, where the instruments just aren't long enough? Have you encountered that yet with a mild patient?
I've not encountered it with mild, no. And I've taken care of some big patients with mild, and I've not encountered it with the allograft system I used, which generally is the PainTech Link system. I've not had that issue. Now, I can share with you, and I'm sure Rick said the same instance where, for stem and pump, I've had instances where I've had the long needle and buried it so that the hub was under the skin. But I'm sure that at some point I'll find a patient that the mild instrumentation or the instrumentation for posterior allograft is not sufficient, but I haven't come across it yet. Michael, what about you or Rick? Have you seen that with those two procedures?
What I see is a lot of chubby folks. They tend to be frontally chubby, and you look at their back, and you can still feel their spinous processes, and that's a good key. And like I'll see somebody in the pre-op, and I'm like, oh man, I need the harpoon, because this says no way I'm going to get in here. And so, but you sit them up and you look at their back, and it's often this obesity is more frontal, more abdominal, and the back fat not always that bad. So, but yeah, I mean, there can be people like that, and I've had Hubbers myself where I'm like, okay, I got a 7. That's about as big as I got, So, yeah, I mean, fortunately, in my population, is not as common of an occurrence, and I try to screen those guys out at the beginning, and try to encourage them, get on Ozempic or Wegovy or some stuff to try to drop it down, which is another thing that we didn't bring up. Okay, so let me just dive into this real quick. So the new drugs, the GLP agonists, Wegovy, Ozempic, others, Mojarvi, whatever it is, they, unless you wait 3 weeks, they got a full stomach. Whether you're doing a shot, whether you're doing an implant, whether you're doing whatever, these people, I mandate at least 2 weeks off of these GLP-1 inhibitors before I would do a procedure. And even at that point, we consider them a full stomach. So the data that's shown so far with gastroenterologists is that it really takes a full 24 days for that effect to wear off. So another key, probably a pre-op consideration when you're doing these patients.
Yeah, no, I think you're right. I think, that's such a wave going across our country right now. It almost seems like who's not on Ozempic, right? Hey, and Rick, I just want to point out, like, you're exactly right. Intraoperative monitoring has completely changed my practice. I used to do everything under conscious sedation or MAC, and now I'm doing 100% of all these cases to keep the patient comfortable, prevent motion that could cause a complication. I'm just making sure that I've got the appropriate setup beforehand. Unfortunately, I've had a couple situations where the scheduler doesn't order the intraoperative team, and I have to say, whoa, we got to go back to MAC, and those days I dread. In the chat box, we got a little bit here, a few questions on smoking. Number one is there a difference in smoking for different types of cases, or do you have a set standard between, telling patients they got to quit smoking beforehand? And if so, how many weeks in advance do you want that? And is there any literature out there to support not smoking?
I mean, there's tons of literature. To show poor wound healing. I mean, Aaron, you addressed this in your prelude, so you should probably comment on this.
Yeah, I'd love to hear Michael and Andrew on this as well. I'm not a, I'm a spine interventionalist, but I'm part of a neurosurgical practice, and my neurosurgical partners will not operate on you if you smoke, period. I don't care if it's a discectomy, whatever it is. I mean, unless it's, some sort of urgent situation, they're going to tell you, you got to quit smoking. And if you're not willing to make that sort of sacrifice, then you can find another surgeon. So that's sort of the attitude in our practice, not for procedures. Obviously, I'll do an epidural or a facet or a radiofrequency ablation, but I feel the same way. If I'm doing an SI fusion, it's a fusion procedure. I'm not going to do it. If Mrs. Jones doesn't want to quit smoking, then she can find somebody else to do the SI fusion, or I'm just not going to do it. I don't think it's worth it. The chance of fusion is much lower than it already is with an allograft, and it increases the risk of wound healing problems as well. So I'm curious what the neurosurgeons think about that.
Andrew, is Andrew on?
Can you guys hear me now?
Yeah, we can hear you now.
Good. How many neurosurgeons does it take to unmute the? Yeah, listen, I agree wholeheartedly with that, with kind of the practice pattern in your group. What I would say is that a couple of things. For better or for worse, I take care of a lot of revisions, a lot of people that have failed fusions. And, one of the most disheartening things for a patient is for them to have a failed fusion, and, they come and see me and they're a 2-pack-a-day smoker. And I say, well, you're never going to fuse if you keep smoking. And they say, nobody ever said that to me. Nobody ever told me that. That's really disheartening for the patient, because, there are a lot of things that will preclude someone or prevent someone or limit their capacity to fuse. Age, osteoporosis, diabetes, these things, we talk a lot about obesity, but what about our patients that are underweight? These are not modifiable factors for the most part, right? Weight, maybe it's modifiable, but you guys know as well as I do, to a certain degree, it's not. Smoking is the one modifiable factor that, you can say no to them, have them come back and have them make a change. And the other thing that I would say is that, as we start to talk about minimally invasive procedures that are aiming to achieve a fusion, you got to realize, even when we do these big open surgeries, and a lot of what I do is a big open surgery, some of these people don't fuse. So, the rate of pseudoarthrosis, even for a big open procedure, is not zero, and it's not negligible. And now you talk about doing a minimally invasive procedure where the dowel might be smaller, the biologic you can put into that joint might be smaller, and we really need every single thing in our corner in order to get these minimally invasive procedures to work. Yeah, so I agree wholeheartedly. Smoking is a hard stop for me.
And how long is it a hard stop? Do they got to stop smoking for 4 weeks, 6 weeks, 3 months? What's your cutoff?
Yeah, so it kind of depends on what we're doing, right? If we're doing a microdisc, and I tell them no doctor is ever going to say, okay, you can start smoking again 3 months after your surgery. But I do tell them, listen, for at least 3 months before and 3 months after your surgery, really need to not have any nicotine. And that's kind of the best data that I've found published is that it's 3 months before, 3 months after. And, the other thing that it's important for people to realize is that smoking, sure, it causes all kinds of complications, right? You get from starting with anesthetic complications, airway complications, you get issues with that. But you also end up with the wound complications. In addition to pseudoarthrosis, you're not going to heal a wound if you're a smoker. Diabetic, it's the same. So the reason I bring that up is that nicotine in itself is part of what inhibits a fusion. And so, I get some folks that come in and they say, yeah, I'll quit smoking, but they come in and they're still using the vape regularly, or they're, chewing nicotine gum, or they got, 5 patches on, and they're like, yeah, I haven't smoked, but they have, 5 nicotine patches and a pack of nicotine gum in their mouth. You're still going to be at risk for the pseudoarthrosis issues. Now, that's better than being a 2-pack-a-day smoker, because at very least you've obviated a little bit of the wound healing issues, but it's multifactorial. And for me, it's at least 3 months before, 3 months after. And I'll go so far as to nicotine test people. And I'll tell them, listen, we're going to have you do a nicotine test 72 hours before the case. And if it comes up positive, if you have nicotine metabolites in your urine, we're going to cancel your case. And I don't mean it as a threat, but we both got to be on the same page for you to have a good outcome.
Yeah, I've heard other people talk about doing the nicotine test as well, getting a urine sample several days in advance. So I was going to bring that up too. And sorry, Andrew, I didn't give you your due, and you're kind of blocked behind my panel thing here with the question, so I didn't see that you're on. But everybody, this is Dr. Andrew Vivas. He's at UCLA with Dr. Michael Dorsey. I got to know you a little bit last year at the CR Spine conference. I'm looking forward to seeing you in about another month and a half there as well. So thank you for joining us tonight. Just real quick, I just see one other question in the chat, and it's talking about, so somebody wrote in, so BMI doesn't affect your outcome. I don't think that's what we're saying. We do think BMI is a factor. It can put stress on, especially if you're putting an implant in and make the implant not work or become defective. So we're not saying that. I think what we're kind of alluding to is that a fit person who works out, their BMI may be falsely elevated. So you got to look at the person as a whole. But somebody who is out of shape, obese, no fitness to them, you got to figure out what your number is. And it sounds like everybody's community is about 40 BMI that you should really, consider, unless the patient is a false positive based off of being a weightlifter. With that, Michael, should we go into some of your cases here?
Sure, let's get rolling and make sure I have control here of the mouse. Good. Yeah, so anyone who's been in any of my sessions, I love to just put cases up and discuss them. That's how I do these. So I found a few cases. Fortunately, even in the area where I work in Ventura County, where we have a very high rate of MIS procedures being done, the complications rates are very rare. And I can't say that I'm seeing a lot of patients come through with complications of these procedures, which is great, because it definitely speaks to real world data for what we see in the published literature. That being said, it's more common than what's been published. So I did find a few cases that we can talk, and hopefully the faculty here can add some color to these, and we'll get through them together and all learn. So this first patient is a 67-year-old who presented to me with low back pain and neurogenic claudication. Said they've had these symptoms for about 2 years, and a year ago had a Vertiflex done it at L4-5, and it was staged to have the second one done 3 months later for obvious reasons. Neither of these provided any benefit. So now they're back a year later. No improvement in their back or leg pain, neurologically non-focal, and coming to see it, get a surgical opinion. So our workup comes up next. Okay, good. So here's image finding. So Rick, I don't know if you're doing Vertiflex or we're doing Vertiflex. What's going on with this X-ray?
Well, you can see the 4-5 is not really in the right location. The superior aspect, somebody's playing the piano in the background. The superior aspect of the Vertiflex is kind of a little too high. So I doubt that there's going to be much displacement. The other thing is that the L3-4 Vertiflex is not really seated on the lamina. So both of these implants seem to be less than optimally placed.
Great. Aaron, you see anything else there? That 3-4 one?
Spinous process fracture.
Yeah, so we got spinous process fracture through 3-4. It's a spondy.
Oh, yeah.
4-5 is almost an auto-fused level. And I looked at the pre-op MRI, and there was no stenosis at 4-5. I'm not quite sure if they meant to do that level at all. Here's the axial view at 3-4, and you can see that with a fractured spinous process, there's all the distraction that could have been gained is gone. So now, here's a patient with severe back pain. They have a little bit of instability. I don't know the flex X here. Wide facet joint at 3-4. Andrew, this is now coming to see you now. Or actually, let's go back to Dr. Kolodny. So a patient comes back to you with a spinous process fracture from Vertiflex. What's your management?
Well, if it's asymptomatic, I wouldn't do a thing about it because it's a potential complication of the procedure, particularly if the implant is not placed ventrally enough. But if they're having pain, it's obviously potentially symptomatic. I mean, what I'm capable of would be to go in. I could remove the implants, but that wouldn't necessarily fix the problem. This, for me, I would refer this to one of my neurosurgical partners, and they might want to do a more expensive, more extensive operation. And there's a lot of stuff going on just these 3 views here that that I'm not sure that I have anything to offer this patient other than to potentially just remove these implants.
All right. Well, you fortunately have Dr. Vivas in your neighborhood to refer him over to. So, Andrew, what are you thinking here? It's primarily the neurogenic claudication that limits this guy. Back pain is there.
Yeah, well, I do want to make one comment just about the kind of decision making to go in with the 2 vertiflexes. I mean, I agree with what's been said. At the bottom level, it kind of looks like there's bone on bone. I don't know. I don't know whether or not the vertiflex was doing much there, but the thing that jumps out at me is this patient has Bastrup's phenomena. They have kissing spinous processes at each level, and it's going to be really, really tough for any interspinous process device to really kind of keep things splayed apart. And so, I don't know that, Vertiflex is maybe the best choice of device, or interspinous process distraction is the best choice of procedure for somebody with Bastrup's. I'll put that on the back burner, but I'm curious to hear everybody's thoughts on that. What we're dealing with now is somebody with neurogenic claudication, but probably some evidence of biomechanical instability. You do have some facet diastasis there on the left side. Certainly more than 3 millimeters of facet diastasis. You do have a little bit of a slip there. I don't know if it's mobile, but you have some ligamentum flavum hypertrophy. I think if the patient had purely just neurogenic claudication and didn't have a large component of axial mechanical back pain, I think it would be fine to do a minimally invasive decompression. Whether you remove the Vertiflex is kind of immaterial to me. You can certainly go in and do a minimally invasive decompression, hemilaminotomy, and do what we call a ULBD, unilateral laminotomy, bilateral decompression. And that's a 1.5 hour surgery, and probably would be able to get all that ligamentum flavum hypertrophy out. Some of the less invasive decompressive surgeries, again, like a mild procedure, something like that, you have that thought, but I don't know if you're going to be able to really work around the Vertiflex and do all of that you need to do and get a substantial decompression with that. I don't have as much experience with that, so again, I'll defer to my more interventionally inclined colleagues. But that's what I'd be thinking of right now. I'd be thinking, Mike, number one, I'd want to get some flexion extension X-rays, see if there's any evidence of instability of the slip. If there's no evidence of any instability, I'd probably be thinking about just doing a minimally invasive decompression here.
Yeah. So
Mike, you said that the neurogenic claudication is still present. You said it hasn't improved.
Oh, he can walk to the mailbox. That's about it. Okay. And that's how it was before all the procedures. So there was some instability here. Speaking to your point about a tubular decompression, the one thing I found with the Vertiflex is they actually stick out laterally a bit. And so docking a tube is a bit of a challenge. I went a little bigger, not much bigger.
I've pulled it off, but you actually have to dock the tube, way further out lateral. You got to dock the tube like 3.5 centimeters out and kind of take a more oblique trajectory, almost the way that you would for like an endoscopic type case. But it is painful. It can be done, but it's painful.
So he ended up getting a minimally invasive TLIF, 2 little incisions, not a big surgery. Left all the stuff in there. The spinous process fracture's healed, so that was good. He's doing well, well out a year out. And of course, now I've fused the level, so chances are at age 67 he'll be back for more at some point. So we'll be having this discussion in a few more years.
What kind of cage is that?
Mike,
That's a titanium expandable TLIF cage.
And then
robot.
There's a quick question in the chat box, and I just want to comment on what Dr. Vivas was saying. It absolutely, Bastrup's disease, you don't know what you don't know. And I think one of my first cases early, when all eyes were on me at the hospital doing a case, I ended up having a patient with kissing spinous processes just like this, and ended up having to abort. I could never get an implant in. And I remember the hospital admin and everybody was asking, and then, you know, I went back and looked at x-rays and all that, and I was like, oh man, this probably wasn't an ideal candidate from the get-go. So I think a lot of times when you're doing your preoperative planning, just like we're talking tonight, you got to look at the x-rays. You know, you're just not looking, you're looking for access, making sure that you can get in, look at that space between the spinous process, you can do it. There is a question in the chat box talking about sizing up or sizing down. So let's say you were able to get access on a patient that's wide open with Vertiflex, and you've got a measurement between. They're asking, should you size up or size down? Aaron, you want to take that one? Do you do a lot of Vertiflex?
I mean, I have over several years, yeah. And, you know, size up, size down, you know, I've heard the argument both ways. I think that if it's truly a split in the middle, and I feel like I can get the larger implant in, I'll put the larger implant in. But you know, the original teaching was to size down. So you know, I think you can make an argument either way, and I'm not sure if anybody has any data to suggest that sizing up is going to create any more like unintended stress that would be more likely to create a spinous process fracture, or if sizing down is going to create a situation where you're going to have subsidence or movement of the implant as that inferior implant, the upper wings seem to move posteriorly. I don't know. What do you think, Dennis?
I think early in my career, you know, you're exactly right, size down. And then I just saw that probably after 90 to 120 days when the implant settled into the bone, they lost the effect. So as long as the patient had good bone quality, I was more apt to try to size up. And I think the other mistake I made early in my career is I was too deep, you know, where I should have had the implant open it a little bit more posterior so I get that bigger size in and then tap it down. And that's also one of those things, you don't know what you don't know until you start doing these cases. But yeah, if you're worried about a spinous process fracture, size down. If they got good bone quality, size up, put it in more posterior and pound it down.
I agree with you. And, you know, there is, as you and I both know, as you begin to do these procedures, you do learn from your own experience and you become wise as you gain more experience. And I understand the situation where you have a Bastrop patient, you want to get that implant in. It can be really frustrating. It just doesn't seem like there's any room. And you know, I feel for you there, particularly if it's one of the first cases and hospital admin's kind of looking over your shoulder, you know, what's this guy doing?
All right, Mike, great case. Let's move on.
So case 2, this is a 90-year-old that I became aware of because they called me from the emergency room saying that his chronic low back pain and left sciatica was worse, so he went to the emergency room. And they sent me his CAT scan, which shows this. And, you know, he had SI fusion 2 months prior, which obviously is not causing his left sciatica or low back pain. So the question here is, Aaron, what do you think went wrong here?
Pardon me, the implant is in the ilium. It's not going to create any sort of fusion, or as far as I can tell, it's not going to do anything for any SI joint pain if he did have SI joint pain. So, you know, if you think that his pain is still coming from the SI joint on that side, then I would say treat it properly, fuse it properly, put in another implant or use a different approach. If the diagnosis was wrong and he's having low back pain for another reason, then I would identify and treat that reason for his low back pain.
All right, and Andrew, you fuse a lot of people in general. How many 90-year-olds do you fuse any part of their body?
God, I try really hard not to. I'll tell you that much. You know, it's tough for these octogenarians and the, you know, I don't even know what do we call people that are in their 90s?
Nonagerians.
Nonagerians, octogenarians and nonagerians. It's really tough for them biologically to fuse. You know, I think that again, we're asking a lot of these kind of minimally invasive implants, and you know, you just got to question whether or not anything's going to actually happen. The funny thing is we've all seen this CAT scan before, right? We've all seen these posterior based implants that kind of go into the ilium rather than the joint. It's some of the patients swear that their pain was better, you know, even though the implant didn't go into the SI joint. So that it makes you think, because these people have no reason to lie to us, right? They're not lying unless it's a placebo type thing. But you know, ultimately, I think that you know, ultimately, I think you're asking a lot for, you know, a 90-year-old to fuse.
Yeah, perfect parlay into our next case. And I would argue that this SI joint might already be fused, honestly. When you really look at it, it's probably already a fused joint anyway. The person who put this in, he said, yeah, the bone was probably just mush. I'm like, yeah, it's a 90-year-old. That's probably why you shouldn't be putting dowels into people's joints at 90. All right, so case 3 here, similar theme to what Andrew was saying. So this is a 45-year-old who's coming to me for left sacroiliac pain. 8 months prior, had the right SI joint fused, 100% relief. And she, I mean, she is as certain as anyone I've ever met that she has 100% pain relief. She can't wait to get the right one done, but had to change doctors because of insurance issues. And so she's coming insistent she wants the same exact procedure on the right. Rick, what do you think of her left SI fusion?
Oh, I mean the right SI.
The right SI, sorry. Yeah.
Yeah. Well, it's a novel approach. I'll have to say that. Again, an intraosseous implant. I can't, you know, one view is no view. So there may be some part of the implant that is actually distracting the joint. And distracting the joint somewhat can actually be beneficial. So if we cut through all these slices and we saw that there was some distraction of the joint, it may actually have some benefit. Hard to say on one slice, but yeah. Well, I would just, you know, do the left side same way, just put it in the ilium and not worry.
Yeah, that's kind of my thoughts. Dennis, any
Don't screw up the joint, whatever you do.
Yeah, I think there could, there's two things, just like Rick was saying, distraction could cause tightening of the ligaments, which may help out. I mean, that may be going on. We don't know. Maybe when they decorticate, they're getting to the mesenchymal cells that are somehow causing that joint to heal.
Stem cells.
But you're right. From this view, it doesn't look like it fused. I think, if you take her at her word, you just treat the other side with whatever approach. But I want to go back, just real quick with Aaron talking about preoperative planning. And I think if you guys have ever seen Chris Bovenet speak, he does a good job about talking about angles and getting in there. And I think, both of these cases probably could have had a better picture or a better outcome if they would have just done some perioperative planning with CT scans and figuring out the angle they had to get into the joint and how deep they had to get in the joint to get it placed. Because I mean, the one on the right, they're not in the ilium, but they're just not deep enough, right? They needed to go probably another 2, 3, 4 millimeters deeper to really get that closer contact and get in the joint,
Yeah, I think on the, when you look preoperative, you do the preoperative planning for these, it's very important to look at the shape of the SI joint as well. And if you attend any of the courses teaching this, you look at a wide open joint like this that's very serpiginous, and you really have to think a lot about what implant or approach you're going to take, because a 8 millimeter graft is not going to distract or do anything to a joint that's more than 8 millimeters wide, as is the case here. This is in the recess of the SI. It's probably not even in the SI joint proper. It's the equivalent of sitting right here. So, all right, we're going to switch out of SI because we have a limited time here and have a really great case. All right, so this is a 62-year-old that Dr. Vivas and I both know. 3-month history of low back pain radiating to the buttocks. History in the past of an L4 to S1 laminectomy, which he did well up until this time. Neurologically intact, except for some weird numbness in his right leg. And it's really, it's kind of, stands to walk, and the back and really more from the waist down into the buttocks really burns, kind of limits his walking. Tolerable, but not great. Had an epidural, helped a little bit for a little while. So comes and sees a surgeon, me, with this image. There. Okay, here we go. So come see me with this image. He's been decompressed 4 or 5. Here's his axials. Up top is L3, L4. 4 or 5 is down below, and 5-1 is on the right. So let's push this to before we even get to Dr. Vivas. Dr. Kolodny, this patient comes to you now. So they have stenosis there at L3-4 with epidural fat, lipomatosis. What's your go-to in a person who's had some relief with an epidural? Is it more epidural? Is it surgeon? What are you doing?
I am muted. I'm sorry. For spinal stenosis with claudication, epidural steroids are, effective occasionally for short term. This is significant stenosis. There's ligament and flavum hypertrophy. I think this is I'm trying to think of a reason. I don't know the punchline on this case. Maybe there's something coming, but I think this is a reasonable candidate for a mild. I don't. The question is there how extensive was the surgery that was done back in 16? That's the only thing. I mean, if there's a lot of bone that's been taken, then I think you'd have a very difficult time doing the mild safely. And so this is a patient I'd really want to look carefully at these images, scroll up and down before I tried to put a big tube in to just outside of the epidural space, particularly if the epidural space is partially obliterated by the previous surgical procedure.
All right. And then are you?
Yeah, go
Sorry,
ahead.
go ahead, Rick.
No, I mean, he's got lateral recess stenosis at both levels, and no matter what you do to the ligament, no matter what you do to the epidural lipomatosis, you're still going to have neurogenic claudication. And that image above is like really, really tight. He's going to need like an ALIF.
Yeah,
All right.
I kind of agree. I think I'm just looking down at that L4-5 slice. I just don't see much of a landing spot bone-wise. I'm sure that's filled with scar tissue. There is a discussion about doing mild where you could use the superior level and then slide underneath and do it. But I'd just be afraid that there's no epidural space and the scar tissue is adherent to the dura, and I'm going to get myself in trouble. I'd send it to the surgeon.
All right. All right. So let's send it to the surgeon. So that's Dr. Davis here. What's your treatment for this patient with neurogenic claudication and epidural lipomatosis?
I mean, I agree with Rick. It's tough to decompress. It's tough to adequately decompress these, even when we do it surgically. I mean, this is not a layup. Getting those lateral recesses decompressed bilaterally is tough. Most of us have gone to doing tubular decompressions, minimally invasive decompressions, and you can do a pretty good, mesial facetectomy and lateral recess decompression on the side that you go in on. Doing the contralateral side, it can be done, but it's technically pretty demanding. People that are very skilled at it, Mike does tons of these. Mike's a very skilled surgeon. He can do it. It's tough. It's tough for a lot of us, myself included. Looking at the 4-5 level, I agree. It seems like he does still have a little bit of lateral recess stenosis there on the right side. At the 3-4 level, it's bilateral, severe lateral recess stenosis, zone 1, zone 2 of the foramen, as well as central from ligament and flavum hypertrophy. So, I think for this gentleman, he had such a good outcome from his prior laminectomies. I'd be tempted to try decompression. I agree with Rick in that, looking at his disc, he's got that disc bulge posteriorly. The disc has the look of one that's probably somewhat incompetent. He's probably headed to a fusion, but I probably wouldn't jump straight to that. I would try a decompression first.
All right, so he goes a different direction. So he ends up getting medial branch blocks for some reason. They provide 0% relief. And then November 2023 has an L3-4 mild. So for 2 weeks, he has the same pain, but worse. 4 weeks, same pain, but continually worse. At this point, he can't stand up straight, very limited ambulation, neurologically non-focal. So we're going to have complication here at some point. What's your workup at this point, Dr. Kolodny?
Well, a good physical examination first, and if If that provides me with just talking to him and examining him, a degree of worry, then I'm going to re-image him, obviously, get MR imaging and see what we got going on, because obviously things have deteriorated over a period of about a month. So I think I would re-image him ASAP.
All
He
right.
needs a CT myelogram.
So he is going to get an MRI, which will also help us out here. No CT myelogram, but that's actually a very good idea. All right, so here's his post mild MRI, which I believe Andrew called me about. So Andrew, what do you think's going on here?
Yeah, I mean, obviously not suboptimal MRIs, what I would call it. Look, I would say one thing to the folks out there in Zoom land. If a patient calls you or tells you, even immediately post-op that their pain is unchanged or worse, that's different than like, oh yeah, I'm having a lot of pain, I'm having a lot of muscle pain, stiffness, whatever. I, as a surgeon, get very worried when the patient wakes up from surgery and says, the pain is worse than when I went in, or the pain is unchanged from when I went in. Because even patients that we do a big fusion on, they can tell you that they're in pain, but in general, they feel different than they did before the surgery. And people can generally, you got to listen to them when they say something like that. So this guy, was telling you the whole time, like, something's wrong. I feel worse.
Yeah, he's got a
seroma.
seroma. He's got a seroma or a CSF leak at that level.
Yeah, so yeah, exactly. Rick, I think ultimately, at the site of the mild, it looks like there's a T2 hyperintense collection there in the epidural space that's causing, critical spinal stenosis bilaterally. What that T2 hyperintense signal is unclear to me right now. Could be CSF. Could have been, an occult durotomy at the time of the mild, and now there's, we talk about it a lot in neurosurgery, but a ball valve phenomena where you make a hole in the dura, CSF can get out, but it can't get back in, and so it creates this kind of pocket. The beauty of mild is that there's no potential space outside of the epidural space where blood or fluid or anything can leak out and get a big pseudomeningocele, but could this be a pseudomeningocele? Could be, could it be a seroma? Like Rick said, could be. Seroma is something that generally happens kind of more chronically over time, and generally doesn't. I haven't seen too many seromas happen acutely and cause neurological symptoms. So maybe a little bit lower on my differential, but CSF is probably high up there. Other fluids which look, hyperintense, things like synovial fluid, things like that, consideration as well.
All right, so we will, for the sake of time here, assume this he has no spinal headache, and radiology calls this a synovial cyst, saying that they went through it a lot and convinced it's a synovial cyst, which is an interesting thing to develop after a mild procedure. Dr. Claudia, what would be your treatment here? Is it a treatment? Is it a referral? What are you doing next?
With this appearance and with a neurologic, patient telling me that he's substantially worse. I've drained a lot of synovial cysts over decades, but I'm gonna send this patient to one of my neurosurgical partners. The story and the imaging is concerning to me. This is not someone who I would try to percutaneously drain.
All right. Well, he did not go back to neurosurgery. He got drained. They drained him, successfully drained a decent amount of fluid. So 2 weeks after the aspiration, he says he's 50% better than he was after the mild, but still worse than he was before. And 3 weeks, they saw him the next week, not any better. So they repeated the aspiration a second time. So that's one aspiration, now 2 aspirations. This is now 12-14. No real difference at all, maybe a little better. Still has the same severe stenosis there that he had pre-operatively. Still painful to walk. So they do a third aspiration where they get 0.1 milliliters. And I assume will look exactly the same with the exact same symptoms. So yeah, I think we sort of got to the point here. At some point, it's great to keep doing MIS procedures, but at some point there's still a role for surgeons, I would say. And I think this is a good illustrative case of that. And just to end with, JD Williams, one of our PSPS members, sent me a case just randomly. He said, hey, I got a great case for that webinar you have coming up. And his case pretty much looks exactly the same, which we lost the slides, but same thing. Pre-op, neurogenic claudication, mild, did well, then got readmitted a week later for pain, readmitted again. So then they went on, did epidurals, finally imaged, again, to Andrew's point, 6 weeks after they're getting imaging when there's an issue right away, and very similar synovial cyst coming off of the joint there after a mild procedure. This one was then referred to surgery and taken out. I'm told the patient's doing well. So those are our cases.
Yeah. Hey, thanks, guys. Appreciate everybody tuning in tonight. Thank you, Rick. Thank you, Aaron. Thank you, Andrew. Mike and I are very appreciative of your guys' participation and willing to come on tonight. I just want to promote next week's webinar. We've got neuromodulation algorithm to treat neuropathic or neuropathic pain and CRPS. Bafi is going to run the show. He's got Lisa Krupp, Enar, Jackie Weisbein, a dear friend, Dr. Gandhi, and Dr. Maddie. So I hope you guys can all tune in. There's the QR code if you want to scan real quick and get signed up. And then last but not least, I got plenty of texts after our meeting in Hawaii. Everybody's wondering where we're going to go to next. We didn't forget about it. We were just working on our location. And since Dr. Michael Lowe is the president, we wanted to go somewhere near his home. And I guess it's also near Rick's. We're going to head to Southern California, to Orange County, to Newport Beach at the Pendry. And hope you can join us. It'll be October 3rd through October 5th. We hope to see you guys all there. Thanks again for joining. Everybody have a good night.
Thank you, everybody.
Thanks, everyone.